Good morning. My name is Ignacio Montaño Callejas. I hope that you and your entire family are in good health during this pandemic period. I would like to welcome you to the 13th SOCOMB 2020 Congress fully online. On this occasion, I will present Learn to Recognize a Conotruncal Fetal Heart Defect. There are 5 conotruncal fetal heart defects: transposition of the great arteries TGA, tetralogy of Fallot, persistent truncus arteriosus, double outlet right ventricle DORV, and congenitally corrected transposition of the great arteries. Transposition of the great arteries is the single most common cyanotic congenital heart disease in newborn infants, and it accounts for approximately 70% of all cyanotic congenital heart diseases, with ventricular arterial discordance clearly present. Transposition of the great arteries occurs in approximately 1 out of every 5,000 live births. Transposition of the great arteries, as we already mentioned, is a ventriculo-arterial discordance, such that the aorta arises from the right ventricle carrying poorly oxygenated blood and goes to the body to return again through systemic venous drainage to the right atrium, and from the left ventricle, the pulmonary artery arises carrying oxygenated blood to go again to be reoxygenated in the lungs. Therefore, at the time of delivery, after the closure of the physiologic shunts of the foramen ovale and the ductus arteriosus, severe respiratory distress will occur, there will be severe hypoxia, there will be acidosis, and there will be cardiocirculatory collapse, and if no treatment of any kind is provided, death will occur. Without treatment, 30% of newborns will die in the first week of life, 50% die within the first month of life, 70% die during the first 6 months, and 90% die within the first year of life. With surgery, the short and medium-term survival is very good. It is over 85%. Here, we have an anatomical specimen showing a transposition of the great arteries, where we can see that the aorta arises from the right ventricle and gives rise to its supra-aortic branches. And from the posterior ventricle, the left ventricle, the pulmonary artery arises. The great vessels are transposed. What are the diagnostic criteria? The diagnosis of transposition of the great arteries can be made during the 21 to the 24-week anatomy ultrasound and must be done using Jegel's 5 views. You will see a normal 4-chamber view. Sometimes there may be a dilated right ventricle. There is no crossing of the great vessels. The outflow tracts of the great vessels run in parallel. That is, they appear like the shotgun barrel sign. In the 3-vessel trachea view, we will see that one of the vessels is absent, and therefore there will be only 2 vessels, as we can see here in this figure. The diagnostic criteria require determining that the aorta arises from the right ventricle and that the pulmonary artery emerges from the left ventricle, and that they run in parallel side by side, with the aorta anterior and the pulmonary artery posterior. It is important to distinguish that the pulmonary artery will bifurcate immediately after its semilunar valve. There is no 90-degree crossing. We recognize the aorta because it gives rise to its supra-aortic branches distally. Therefore, there is no crossing of the great vessels. There is a parallel outflow of the great arteries. The 4-chamber view is normal, and in the 3-vessel trachea view, there will be 2 vessels, the aorta, the vena cava, and the trachea. This is the skateboard sign. Here again are images of the anterior aorta and the posterior pulmonary artery, which bifurcates. Here we see, with color Doppler applied, the great vessels in parallel side by side. These are images in which we can see a transposition of the great arteries, in which the pulmonary artery emerges from the left ventricle and then immediately courses posteriorly and bifurcates right after its semilunar valve. In the 3-vessel trachea view, the skateboard sign shows 2 vessels. In the 3-vessel view, we only see 2 vessels, the aorta, the vena cava, and the trachea. Here we see the image of 2 vessels in parallel. And finally, here again, we see a 5-chamber view. From the posterior ventricle, the pulmonary artery is seen in this image bifurcating immediately, that is, as close as possible to its semilunar valve. So we have the shotgun barrel sign, where 2 vessels are seen in parallel side by side, the anterior aorta and the posterior pulmonary artery, PA. Here we see that the aorta emerges from the anterior ventricle and the PA emerges from the posterior ventricle. At the 2016 conference, we presented two clinical cases. One was diagnosed during the 21-24-week screening period, and the other was diagnosed on fetal echocardiography at 27 to 28 weeks. We can see that in this image, it is the first case, a normal 4-chamber view. We can see a wide foramen oval there, and when we then evaluate the outflow tracts, we see that the pulmonary artery emerges directly from the posterior ventricle, the left ventricle, and the aorta from the right ventricle. This case had a paramembranous ventricular septal defect. Here we can see the great vessels side by side. We are looking at a transposition of the great arteries. Here we can see the anterior aorta and the posterior pulmonary artery, which branches immediately. So please remember that conotruncal heart defects have a normal 4-chamber view except for corrected TGA. Here we are looking at a transposition of the great arteries where we see a normal 4-chamber view. The shotgun barrel sign is here, and in the 3-vessel view, there are only 2 vessels. Here we can see the image of transposition of the great arteries, the aorta anterior and the pulmonary artery posterior. This was the second diagnosed case. They came for the 21-24 ultrasound, and the heart evaluation on the 21-24 ultrasound was insufficient, so they were scheduled for a re-evaluation. We performed a fetal echocardiogram at 27 to 28 weeks, and we observed and evaluated that the pulmonary artery arises from the left ventricle, and as I mentioned previously, it bifurcates immediately and courses posteriorly. Here we can see that the pulmonary artery arises from this posterior ventricle, and that on the 4-chamber view, it is normal. Here you can clearly see how the pulmonary artery emerges from the left ventricle and then branches. This is a lateral 4-chamber view. In the 5-chamber view, we again see how the pulmonary artery immediately emerges from the left ventricle and courses posteriorly, and here we see the complete evaluation. So we see the 4-chamber view, the valves move freely, and when we try to obtain the outflow tracts, we see that this first vessel bifurcates immediately. Therefore, it is the pulmonary artery emerging from the left ventricle. And if we continue trying to obtain the 90-degree crossing, the crossing is not present, and we will see that from this anterior ventricle, a straight vessel emerges that runs from anterior to posterior, which is the aorta. And when moving up toward the superior mediastinum, in the 3-vessel trachea view, we only see the transverse aortic arch and the superior vena cava. The pulmonary artery is not seen because it is below the aorta. Therefore, in the 4-chamber view, there is a patent foramen ovale, and additionally, in the 3-vessel trachea view, there is antegrade flow at the level of the aortic arch, the vena cava, and the trachea. The pulmonary artery is not seen because, as I mentioned, it is below the aorta because it is in parallel. This is a third case that had a normal 4-chamber view and came in for an ultrasound at 16 weeks. The 4-chamber view was normal. This vessel emerging from the posterior ventricle was interpreted as the aorta, and this vessel that apparently arose from the right ventricle was interpreted as the pulmonary artery. This case was a false negative at 16 weeks and 4 days. When it came in for the ultrasound at 21 to 24 weeks, what we are going to observe is the following. We see a normal 4-chamber view. The 4-chamber view looks normal, but in the 5-chamber view, we see that it is abnormal. We are going to see that the artery emerging from the left ventricle is the pulmonary artery. Therefore, it was a transposition of the great arteries. Here we can see the vessels side by side, the aorta anteriorly and the pulmonary vessel posteriorly. Here, the semilunar valves can be seen side by side. This was a case that was identified at 21 to 24 weeks. Here, we see the same thing, the shotgun barrel sign with the 2 vessels side by side. There is antegrade flow in both the aorta and the pulmonary artery. Here, it seemed to be going from left to right, but please notice here how the pulmonary artery goes slightly anteriorly and then turns posteriorly and gives off its branches. And from this anterior ventricle, we see this vessel that is straight and does not branch. Therefore, this is the aorta that is anterior, it is transposed. And in the 3-vessel view, here we clearly see in the 3-vessel trachea view, we will clearly see here 2 vessels, the aorta with its anterograde flow, the vena cava, and the trachea. We do not see the pulmonary artery because it is below the aorta, since it is transposed. Therefore, this is a sign of transposition of the great arteries. Instead of 3VT, we will look at 2 vessels, aorta, cava, and trachea. Here again, transposition of the great arteries. Same case, we see antegrade flow in the aortic arch. And here, this is a new case that was evaluated by a colleague who suspected transposition of the great arteries. They called me immediately, and between the two of us, we confirmed that it was a transposition of the great arteries, where you can see here the great vessels side by side. This was also a false negative on the ultrasound at 21-24 weeks, and it was picked up at 27 weeks. Once again, the two vessels are parallel. This is a new case. A colleague suspected transposition of the great arteries and referred her for a fetal echocardiogram. Here we can see the fetus is in a cephalic presentation with its back to the right, and it appears the fetus has a normal four-chamber view. When we are going to evaluate the outflow tracts, we will see the same thing again. The shotgun barrel sign, two vessels that emerge side by side in parallel. The pulmonary artery emerges from the left ventricle and the aorta from the right ventricle. They are parallel side by side. There you can clearly see the well-known skateboard sign. The aorta, the vena cava, and the trachea are all clearly visible. This is another case of transposition of the great arteries. And this patient also had a completely normal four-chamber view, which is very important to keep in mind in this particular type of congenital heart disease. Here you can see the skateboard sign. Aorta, vena cava, and trachea. Another case in which a colleague evaluated her at 21 to 24 weeks and suspected that there was a ventricular septal defect. There were abnormalities in the outflow tracts and an abnormal three-vessel trachea view. She was referred with that suspicion, and we evaluated her and immediately saw that the three-vessel trachea view was abnormal here. We only see two vessels, and here we can see the well-known shotgun barrel sign, two vessels in parallel side by side. With color Doppler, we see how the two vessels arise in parallel and are transposed. Again, here we can see that the aorta arises from the anterior ventricle and the pulmonary artery from the posterior ventricle. And in the three-vessel trachea view, there are two vessels with forward anterograde flow. Again, parallel images. There is forward flow in both and in the three-vessel view. Here, the skateboard sign is clearly seen, where the aortic arch, the vena cava, and the trachea are present. The pulmonary artery is not seen. Here, the three-vessel and trachea view is clearly seen. Two vessels and this classic shotgun barrel sign with the aorta anterior and the pulmonary artery posterior. Again, there and here, we see how the pulmonary artery is emerging from the left ventricle and immediately bifurcates, and here in stick volume, how these vessels run in parallel, side by side. We can say that in transposition of the great arteries, 20% of these children will present a restrictive foramen oval, and that will lead to severe hypoxia and acidosis after birth because the shunts will close, the foramen oval and also the ductus arteriosus. So this becomes a critical situation, an emergency. Therefore, an atrial septostomy must be performed to allow oxygenated blood to pass into the systemic circulation so that severe hypoxia does not occur and to prevent acidosis and morbidity in these children. So, an atrial septostomy involves placing a balloon through the umbilical cord. It is an emergency. The neonatologist or cardiologist will place a balloon catheter and insert it through the umbilical vein into the inferior vena cava, reaching the right atrium, passing into the left atrium, and from there it will create a perforation or enlarge the foramen oval, allowing oxygenation to stabilize the baby so that the baby can then proceed to surgery. Children with TGA, once they are born, should be started on prostaglandins, have an atrial septostomy performed, and then undergo the arterial switch soon afterward. This is performed within the first 7 to 10 days of life. This is a surgery at the hospital for a TGA, where we can see here that the aorta arises from this anterior ventricle. The pulmonary artery is not visible because it is below, transposed. Here we can clearly see that this is the right ventricle, with the aorta emerging here. This is the aorta, and the pulmonary artery is below it, meaning it is in parallel. Here it is in the middle of the procedure. They are quite lengthy surgical procedures that require cardiopulmonary bypass. We can say that the prenatal diagnosis of TGA contributes to better postnatal management of the newborn and improves surgical survival. Transposition of the great arteries is the heart condition least often diagnosed on the 21 to 24-week anatomy ultrasound. Worldwide, the diagnosis rate is only 20%, and this is because it is a congenital heart condition that is not associated with chromosomal abnormalities, and also is not, or only very rarely is, associated with extracardiac abnormalities. The surgery is corrective and has an infant survival rate of over 90%.